Thank you, Tyler. And welcome to all of you on the webinar. Good evening, and thanks in advance for taking time out of your busy holiday season to participate in the Alpha Voyage, the first ever SVS VA Committee webinar. As I'm sure you'll recall, the SVS VA Committee is the brainchild of our SVS immediate past president, Dr. Bruce Perler. The mission of our committee is to enhance the quality of vascular care provided within the VA system by examining portions of the greater VA mission of clinical care, education, and research, decoding some of the secrets and allowing us all to better appreciate the potential of the VA by sharing our knowledge. Our committee has convened several times already over its past short life, and we developed 4 subcommittees or working groups. The first is with an aim of improving the VA work environment for vascular surgeons by advocating to VA leadership. The second, a group to improve the ability to do vascular research within the VA system. The third, to improve patient care by reaching out to primary care providers and extending to them information about vascular disease. And the fourth, to improve the quality of work life by enhancing connections among VA vascular surgeons. So tonight, you'll hear what we think are focused topics in each of these 4 categories by the speakers who I'll announce shortly. So we'll start right off, and we have a pretty packed agenda. We're hoping in this few weeks following the VEITH meeting to follow the typical VEITH short, high-power presentations and leave adequate time at the end for questions. So I'd like to start with Dr. Michael Amendola. He'll speak to us about AAA screening and treatment within the VA system. Michael is an associate professor of surgery at Virginia Commonwealth University Health System, and he works at the Hunter Holmes McGuire VA Medical Center in Richmond. Michael?
Thank you very much, Dr. Zolak. Thank you very much to the SVS and for establishing this committee and allowing us to participate tonight. The contents of this presentation don't represent the views of the United States Department of Veterans Affairs nor the United States government, and I have no commercial disclosures. I will briefly detail our subcommittee's members, goals of our work to date, what we've delivered to the SVS and the VA community at large, future directions with our work, and then take any questions that you have via voice, text, or email. Our subcommittee consisted of 4 vascular surgeons ranging from the Cleveland VA and Case Western University to Ann Arbor to New Haven, as well as me in Richmond, Virginia. Our primary goals of our subcommittee were to develop and distribute educational materials directed toward VA Affairs hospital primary care physicians, in particular to educate VA primary care physicians about peripheral arterial disease and abdominal aortic aneurysmal disease. The secondary goals were to increase vascular surgeons and SVS awareness among VA hospital primary care physicians to introduce referral guidelines currently in place in a variety of VA practice. With that in mind, we produced 2 separate and distinct reference slide deck presentations directed at each disease state. These educational instruments were designed with the idea of general distribution to the VA primary care base. They were also created with the idea that on-site local vascular surgeons could utilize the material on their own presentations to this audience. Delivery of this content is scheduled for downloads from the SVS website, in particular a section dedicated to the VA vascular surgeons, and potentially as a resource for referring physicians. Details of these presentations including defining the disease state, outlining physical exam findings, examining common interventional and open treatments. Unique to these presentations is defining the appropriate vascular duplex surveillance criteria and triggers for referral. Inherent in all the content is the unique role that vascular surgeons play in the management of these disease states. These presentations were designed such that local vascular surgeons could utilize parts or all of the material for modification of their own presentations directed toward their local primary care base. Our future endeavors will include expansion to other disease states, We also plan to showcase different procedures and approaches that vascular surgeons can provide to a primary care base in terms of care for the patient with vascular disease. Additionally, collaborative online educational environments could possibly be utilized to further initiate, strengthen, and define referral patterns within the VA. So in conclusion, there's great potential in the educational-based endeavors for the VA vascular surgeons. We hope these materials sponsored by the SVS and created by VA vascular surgeons will help define our role and emphasize its unique strengths. Such interactions that coordinate local and national forces will serve as a catalyst to create and strengthen lines of communication with the primary care base referral that is currently present at the VA. Thank you for your time, and thank you to the SVS for the opportunity to serve the VA vascular community and the organization at large. I look forward to any questions, either now at the end of this presentation or at the end of the webinar in general, or via email, as you can see here. Thank you.
Michael, thanks very much. I think what we may do is give perhaps 3 presentations and then take a break for questions, because sometimes people will be thinking about these questions or take a few minutes to type them in. So I think we should go ahead with Vivian's presentation. Vivian Halpern is next. Dr. Halpern will speak on the status of the VA vascular surgeon, in particular efforts that she has made that are, in my opinion, nothing short of spectacular, to create a listserv that shares vascular surgical information across all VA vascular surgeons who are interested in that. Dr. Halpern is a clinical associate professor of surgery at the University of Arizona College of Medicine, and she's the chief of vascular surgery at the Carl T. Hayden Phoenix VA Medical Center. Dr. Halpern?
Hi. So I have the same disclosures as Dr. Amendola, which is none, and that this does not represent the viewpoint of the VA at large. My impetus, along with a couple of other folks, Dr. Jean-Claude at Cleveland and Alan Dardick at Yale, we got together one SVS and said, you know, we all have these problems. We all talk about these problems. We have the VA and how to figure things out, and everybody has kind of different solutions. And we all want to serve our veterans better for vascular care, so how can we get together? And that was sort of the impetus. And I have to thank Lori Pounds, because at her VA, she was able to have the actual VA website, VA email set up for us. We want to our aim is to try and standardize our care and our ability to give care for vascular patients across the entire VA system. We are up to 100 members in our VA email grouper, and anybody who's on the line who has other people that they think should be added to our VA email grouper, please send them to me. My email is vivian.halpern@va.gov, and my name is spelled as VIVIENNE. And the VA email grouper address is on the slide presentation there. And we have been using it quite well, I believe, to communicate issues or questions or even equipment questions about surgical clips today and hybrid ORs and various other topics where we've been able to communicate with each other and give each other ideas of how to get something accomplished at our own individual VAs. We've also started a share drive. The web address, again, is on this slide. I'm sorry I couldn't highlight it better, but it's down near the bottom of the page. Now, unfortunately, the share drive can only be accessed through the VA system because the share drives are considered secure by the VA system. But we've already had some inputs for PDs to get vascular lab staff and equipment requests. There's been some information on research. Dr. Amendola has posted some of our slide programs on the website to give to the PCPs. And, you know, it's really for anything that we feel it is, and everybody is welcome to have input to put items that we think are important to share with each other and to help us function better at our individual VAs. We've also, and I think somebody else is also going to be talking about how difficult it is to recruit and retain qualified vascular techs. And I have been working on setting up an email grouper for vascular techs to communicate with each other as well. And the question has come up as to whether to share our share drive with them or create their own share drive. My personal bias is to have them share our share drive, because then we can post our PDs or equipment requests or other things that we need to get the equipment that we need to have a highly functioning vascular lab. And any other communication suggestions would be welcome. But that is our impetus to get us all together to share ideas and create a good vascular environment for our veterans.
Thanks very much, Vivian. This shared email link, I think, has been remarkably effective. I just can't say enough about it. It's today's discussion was about Yassergill clips, and there's tons of little things we all need to know about that this has helped us with. So thanks very much. We'll save questions until after the next presentation. Next up is Dr. Gail Tang. Gail is going to speak to us about a VA vascular research survey that she has conducted. Gail works at the VA Puget Sound Healthcare System and the University of Washington Vascular Surgery Division. Gail?
So our research subcommittee currently is myself and Wei Zhao, and Edith Zhang was originally a member but stepped down because of other commitments. So we wanted to sort of get an idea of the research needs between the different VAs, and so issued the survey, and I thank all the participants who took the time in their busy schedule to fill out the surveys. So we wanted to identify several different things. First was identify the areas that the VA vascular surgery community thought were the most important areas for research within vascular disease. And then we wanted to also identify local resources as well as common problems that hindered the progress of getting research done within the VA system. We wanted to identify those researchers who would be willing to participate in multi-centered VA clinical research, so as to assist anybody who's thinking about doing a multi-site or clinical trial or a VA co-op study. And then the last was to determine whether the environment for potential mentors for junior VA vascular surgeons. So just a quick overview of the survey respondents. There was a 32% response rate. 77% of the respondents had active research projects currently going, so the vast majority of the people who actually responded are currently involved in VA research. The respondents came from 24 different VAs scattered around the entire country. Every single region was represented within the survey respondents. There's a list of the sort of breakdown of the academic interests listed on the slide, so I won't review that, but let you read it. And happily, 30 out of the 31 participants were willing to participate in multi-centered VA research, suggesting that people are open to collaborations and to multi-centered trials. I've listed on the slide sort of a summary of the key research questions that in different categories of research that people thought should be focused upon. The carotid disease was very much in line with the current ongoing CREST-2 trial, and the open versus endo for lower extremity revascularization was also in line with the ongoing BEST trial, which several VA centers are participating in. And then interestingly, because I think of the variable response to the choice program and the varying care that our veterans have received in the private sector, there was some interest in determining healthcare utilization in comparison to private sector in terms of vascular surgery care and results. The research support that was available, the most common thing was a nonprofit foundation supporting research at a local VA. There was also the Clinical Research Corps, Tissue Bank, and Data Research Corps were also more frequently mentioned. Interesting, there were 7 different VAs that had 2 respondents, and there was a lack of congruency between those respondents in terms of what they listed as available research support, suggesting that the respondents were not necessarily aware of all the resources available to them from their own local VA, which may be an area that we can direct assistance in the future. In terms of factors limiting research, the highest rated was administrative burden. Lack of funding was second, and then the others as listed. Interestingly, lack of mentorship, this was on a scale of 1 to 5, with 1 being the most important, so a low score meant that people thought it was very important, and 5 being not so limiting, suggesting that people have not struggled with finding appropriate mentors. Of the respondents, about half of them were willing to serve as research mentors in various topics of their expertise. So in conclusion, the results of the survey suggest that there's no burning issue that dominates where people thought that VA vascular research should be directed, but there are multiple sites of interest. There is existing research support available at many VAs, and there is a robust group of vascular surgeons willing to participate in multi-centered research. In terms of the limiting factors, I don't have it up there, but because of the administrative burden, I've noticed that one of the factors for success in bringing online sites that Phil Goodney's PROVE trial has is that his team has been willing to assist with local IRB paperwork, and that would be a suggestion for anyone who's thinking about multi-centered VA research to have a portion of the funding allocated towards taking care of the administrative burden within each VA. So that's all I have today. I believe everyone has my email because it was related to the survey. The survey is still open, so if you're interested in responding, I will leave it open and continue to collect data for at least the next month. And thank you again for participating.
Gail, thank you very much. That's a great presentation, and it's doing a service to us all by collecting the data about research in the VA. The VA is sort of one of the last bastions where we have just a few minutes each day where we can potentially do some research. So thanks. There are a couple written questions, and I think we'll take a break now from the presentation to look at those. The first question that was sent in was, how do we best measure success in our ability to reach the primary care physicians with SVS materials? Michael,
I can take that. I think the way to handle that is to, in some ways, monitor when materials are downloaded. Clearly, from the technology exists to monitor that, but I think more importantly, to capture when a primary care, and maybe even have 2 portals for information, maybe a portal for vascular surgeons locally to download materials, but also primary care to download similar base materials, and capture that in 2 reasons. One, potentially to elicit maybe a needs assessment from primary care to see exactly what kind of educational materials they would like, but also to link them to a VA that we could feed back from our committee back to that VA vascular surgeon, say, hey, your primary care base has reached out to us. Hey, they're looking at these materials. You might want to follow up with something, either live face-to-face or an email or some kind of written communication to kind of strengthen exactly what is going on in that local VA. So I think we can capture those statistics based on downloads, but we can also make the local connection but furthermore, make the connection to the primary care and kind of get an understanding of what they really need from these educational materials so we can direct future instruments toward those needs.
Thank you. That sounds like an excellent idea. Okay, good. Another question now is, do we have a way to connect and share information with vascular nurses in the VA system?
Yeah, I type back in. I think it's a great idea. It's a little harder to gather the information as to who has actually designated vascular nurses. We actually only just got one recently. We had previously a shared model, and I know several sites also have shared models, so they don't have dedicated vascular nurses. One thing I'm trying to work on with the nurse practitioner who's on our service is for at least the mid-levels to have a connection, vascular mid-levels. But if you have ideas as to how to connect the nurses or a way to gather that information, I will check with our nursing leadership to find out if there's a way to find that out, sort of more easily and globally.
It does seem like having starting a similar email list for the vascular nurses or mid-level providers might be a starting point so that they can have a discussion about issues that relate to their position.
Right, but you have to know who those people are to start the, somebody has to gather the information for the personnel that would go onto that server. So that's what I'd have to find out. How will we gather the information of who those people are?
Mm-hmm. All right. Well, that's a really good suggestion, though, because I think most of us do have at least one person we could call the vascular nurse or vascular associate provider that will get a lot of information from a shared email system, as have the vascular surgeons.
Mm-hmm.
Okay. Well, I don't see any other immediate questions, so let us proceed. Our next speaker is Dr. James Goff, and Dr. Goff will speak to us on what is really good news, the new VA physician salary tables. Dr. Goff is the Chief of Staff at the New Mexico VA Healthcare System, and he's a professor of surgery at the University of New Mexico School of Medicine. Jim?
Thanks, Bob. So my first disclaimer would be, like everybody else's, I don't have any disclosures, and certainly what I'm about to tell you is my opinion and not necessarily that of the VA, particularly for the role that I'm in. Before I start, though, I want to just give a little shout out to Bob and the Vascular Surgery Advisory Board for the VA. One of the things that really was the impetus for the pay tables to change is the advocacy we've had, and Bob was a recent chair of that committee. And they've done a lot of work to get us to where we need to be. So I'm going to go through a few things quickly. You have the slides to download, and I'm certainly happy to answer any questions by email even after we're done. So really what we need to talk about is three components of salary, not just the pay table. First, what the pay components are. The second would be the 3 R's. And the last is the compensation we really don't talk about very much. So all the pay components that we have are pretty straightforward. There's a base pay, and all physicians are GS-15s, and they're on a pay scale that goes up about every 2 years with a step increase, which is about $3,000, sometimes a little bit more. And that occurs automatically on everybody's anniversary date. The reason that's critically important is that there are a number of people who will use that known increase in salary to try to figure out how they could reduce salaries down the road. The second thing is market pay, which is in a specific range. And then really the annual pay and the base pay and the market pay together make up annual pay, and that's what's eligible for people's retirement. The good news is, and I'll talk about it in a minute, is that we now have a new pay table, and we're still in pay table 4, but we actually have had a significant bump in how that's in the amount of compensation for which will be eligible. And then really the last part about this is, how does anybody determine what the annual pay should be? It's based on a compensation panel that's done at the facility level. So it's done at your initial hiring, and then it's done every 2 years. It's based on the table and tier, table being where the specialty is, and tier meaning what your role is, whether you're a staff surgeon, a section chief, a service chief. There is no tier 3 in table 4, and I'll show you that in a minute, because I think we're now in the most highly compensated table. And the last thing is, depending on the salary amounts, and every VISN is different, it may require approval at the VISN and VACO level. Now, what I just heard at a recent meeting with some chiefs of staff is that number is still 300 for most VISNs and 350 for approval at VACO, so you may have to make sure that the justifications are well written, even though the pay scale has changed. So what you can see is the new pay table that was effective on November 13th of this year. We're now on pay table 4. You can see the red, blue, and kind of yellowish or burnt orange colors that shows you where the changes are. There's no more table 7. That used to be the highly compensated table. We are in the most highly compensated table. So 3 cheers again for the Vascular Surgery Advisory Board, because this is where we should have been all along, given all the interventional work that we do. And it's a real plus for us to be able to have this as a recruitment tool. But this is publicly available, and you can see where the other surgical subspecialists now land, and also the other people that are now on table 4. So if you're in a place that's having a difficult time with those recruitments, you can share with your colleagues that things have changed. I will just go through this quickly. The 3 R's are recruitment, relocation, and retention. We can also use these as pay tools to try to increase people's pay. I will tell you retention tends to be the toughest, and it's going to get tougher in our environment, given the fact that the pay table has a significant increase in salary up to $400,000. The compensation we don't talk about, I wanted to spend just a minute on. You know, we have educational debt reduction program, which is basically meant for student loans, either for people that were newly hired or for our existing staff to keep them. It is dependent really, though, on the local specialty priorities and the funding that's received on an annual basis. There's an allotment for both facilities, and then there's a national allotment, but the facility really has to prioritize what those specialty areas are. So you may have a facility that the priority is podiatry one year because they're short podiatrists, and they're going to use this as a recruitment and retention tool, and vascular surgery may not be included. So it's important to have a conversation with your local leadership about what's what. And then with respect to CME, this is also something that's being pushed at the national level. Usually everyone is eligible for $1,000 per fiscal year for CME, but my observation is most people don't even know it's available and they forget to submit anything. And while $1,000 isn't a lot of money, it's $1,000. And so some facilities are able to plus up that amount with things from the education service if you submit the request far enough in advance and it justifies the mission. And there is a move at the national level to try to increase that amount for CME. The last 2 pieces that we don't talk about are really protected research time. We have the ability in the VA to actually give people protected 8ths. And so they're compensated for when they have dedicated research to do. And I think this is an attractive recruitment tool to try to get new faculty and existing surgeons to participate in VA research. And the last piece is the retirement plan. Until we have a change, and we'll see what happens with the next administration, we still have a defined benefit plan, which is retirement pay, and then we have a defined contribution plan, which is the thrift savings program, which is like a traditional 401k. I think something that people don't know is that for those high-end earners that wouldn't normally be able to contribute to a Roth 401k, they're able to do that in this system, and they can put in catch-up contributions into the Roth component. And so I think that's something we need to talk about with people too, because it's a little bit different than the private sector. I post this here. When you become a surgeon, when you're a surgeon and you go to the dark side of the force, as I've done to become a part-time bureaucrat. Thankfully, I'm not a full-time bureaucrat yet. I think I have some insight into how the system works. I was fortunate to be a section chief, a service chief, and now a chief of staff. So if anybody has questions about process, I'd be happy to answer them.
Thank you, Darth. Oh, that was terrific. We really appreciate that information. I suspect in these last few minutes, every one of us on the phone learned a few things that we didn't know before this call. And the pay tables certainly do offer us an opportunity, at least, to be competitive when we try to reach out and hire folks. The next presentation will be by Lori Pounds, and Lori will speak on vascular surgeons' workload credit for cases done in the interventional radiology suite. This has been a frustration, I suspect, for almost all of us now that we do a large proportion, if not the majority of our cases interventionally. Lori is the Chief of Vascular Surgery at the Audie Murphy VA Hospital in San Antonio, Texas. Lori?
Thank you, Bob. I have nothing to disclose, and I appreciate the opportunity to speak today. So at one point in our institution, we had a protocol set up for our surgeons. We had surgeons who were coming over from the university, and we only had a portable C-arm in the OR. and they were going to the interventional suite to do their cases. And so the scope of the problem is access to fixed imaging suites in the operating room is not available. So when surgeons do move to other departments, they want to do their fixed imaging for the complex cases. And as Dr. Zolak stated, workload credit may not be captured when this happens. So the solution that we had established at one point was that cases were posted in a surgical package and an interventional radiology. All right, so there would be the nurse would post in two separate areas. So it was double work on that aspect. At the time, the radiology chief and the AO for radiology and surgery were agreeable to doing this. And this is going to be my little asterisk disclaimer, okay? The CPT codes would be entered into Vista. In the PAC system, they have to have a dictation to close out that open encounter, or it stays open and creates strife on some administrator's board. And so the surgeon would dictate a dummy report, such as, please see the surgery tab for full report, that would close that encounter in the PAC system, and then Vista would just say that. Then people would go to the surgery tab, and the case would be dictated in the op notes like you normally would. At that time, for billing, the university, since it was contract, the university would send someone over that had access, and that person would be able to pull by physician the operative load notes and be able to then, give a charge to the VA and get the credit for that. So in return, that credit was then also established to the vascular surgery service in that was being done. So even though it wasn't quite workload credit, it was a little bit different on that. It was a way of tracking both of these. Now, the pitfall, or some of the things that we ran into, is that IR would capture the facility fee credit. And so even though the surgeon was getting this credit, in theory, IR was capturing the facility fee credit. A lot of people actually had no concept of what that really was in the VA, and so we had stopped really kind of worrying about that. This, again, all depends on your radiologist wanting to have this collaborative process. And at the time they did want that, as they were short on interventional radiologists, and so it kept their suites busy. There's very many moving parts, and it was extra work for the vascular nurse to post a case. And so if that person was not there that day, or there was somebody filling in, it pretty consistently did not happen correctly. And then that would lead to, confusion and delay. And then the other asterisk disclaimer is no one can really confirm that it truly works. Since you don't really get a workload credit itemization, you could not check it. We could check on the university billing side that the physician did get credit, and that was billed back to the VA, but the VA system itself could not actually confirm one way or the other. This was just, through a bunch of emails, how it was set up. I think really, truly the long-term solution that we need to have is that you really need to have an AO in surgery and really a front office that's supportive of a fixed imaging endosuite that's in the operating room. And for me, that was very feasible because the AO for radiology actually was a cath lab tech and really understood the concepts of the dynamics of how this worked and what it would bring to the facility. But it was sold on that any service can use this. So vascular surgery, IR, cardiology, cardiothoracic surgery, we try to make it a multi-specialty room. The front office was receptive, and quite frankly, the biggest thing was the talented biomedical engineer who took this project on, and she was very meticulous and very good about following it through. And then I was there for weekly meetings planning the lights and making sure the boom didn't fit, bump into different things. So it was a fair amount of work that really also had no workload credit to it. So it did take 5 years, but I do have a hybrid suite now. Then that has been just a beautiful joy to have, I must say. Now, the third disclaimer that I have for this is now we're trying to have radiology come upstairs because one of their suites is going to go renovation. And now our current surgery AO is not receptive and will not work with them so that they could we could return the favor and have their doctors come up. So I don't think that has really worked out as much as I would have. But thank you so much for the opportunity. If there's any other questions, I'd be happy to answer them.
Lori, thank you very much. Congratulations on what looks like a beautiful hybrid suite. So I have the privilege of giving the next brief presentation. It's about enhancing vascular lab technologist salaries so we can be competitive and hire high-quality vascular lab techs. So let me see. I have no conflicts. So this is about the challenges for the VA vascular lab. As we all know, if you try to be a high-quality vascular surgeon without a high-quality lab and lab tech working at your side, it becomes extraordinarily difficult. And in the VA system, the lab has been a poor sister. It has been nearly impossible to hire vascular laboratory techs for several reasons, the most obvious of which is that salaries aren't even close to being competitive. Vascular laboratory techs in the VA system are categorized as medical instrument technicians, a title which is demeaning, if not frankly insulting. And then in many facilities, the GS level of the vascular lab techs have been 7s and 8s, rarely a 9, and even less rarely a GS10, so that with a federal pay scale, it has really been impossible to hire people. And so we have no technologists, or we have technologists who come and work for a salary and are maybe not the best people in the world, or we have technologists who come for a short time, and if they're good, they leave to a much more better salary job in just a short period of time. And so it's been extraordinarily difficult to gain a foothold in the realm of high-quality vascular labs. So here's the slide. As we've heard a few minutes ago, the retention bonus mechanism, which several people have tried to use to retain vascular laboratories, is going away within the VA system. It is becoming increasingly difficult to use a retention bonus. And so there are some workarounds. And the ones that I'll address today are trying to get the highest possible GS salary range, which I believe is a GS10. And there are a few vascular laboratories in the VA system in the country that have posted jobs at a GS10 level. But then the problem is that the requirements in your functional statement or your position description for the GS10 vascular lab tech become so sophisticated that even a really good technologist doesn't qualify. So you recruit saying to people they might be a GS10, and then when they potentially accept your offer, you go through all the hoops for qualifications, and you find that some board has identified your highly qualified candidate as a GS9 or even a GS8 and downgrading their potential salary. So getting a GS10 is good, but there is a potential downside. The system that I'd like to describe to you in the next few minutes is actually a mechanism named a salary survey to get a special rate. And this is something I try to do at my VA. It took me as long to accomplish this as it took Lori to get her hybrid suite. But in the next couple of slides, I'll show you just a snippet of the paperwork that is required. So So you see here, this is a salary survey. It's on the standard VA memorandum paper. It's about in our shop, it turned out to be about a 15-page document. It just happened recently, June 1st of 2016, and it took me 5 different HR specialists until I found one who would actually put in the major effort to do this. So in the appropriate VA Handbook 5007, there is the option for facility directors to be authorized to establish, adjust, or cancel special rates for hybrid 38 occupations, and that includes a vascular lab tech. And what it requires is proof that you've been unable to hire, which is common for many of us, and documentation of local salaries, which you can now, of course, get from Hay Adams or a number of other analysts who publish competitive salaries for a variety of positions. And if you accomplish all that data collection and justification, then you can go on and with the support of your local front office, you can, in fact, obtain a special salary rate. So here, number 3 describes the worksheet that we used, but number 4 is starting salary rates that's set using the rate range maximum of $60,700, and we chose to set the GS7 Step 1 at $56,000 in order to maintain a 6% grade differential and to stay within the authorized percentage supplement maximum of 69%. That sounds fairly complicated, but here's the bottom line. This represents a 60% increase over the underlying GS base pay schedule. 60% was used to set the remaining steps of GS7, GS8, and GS9 were set in equal proportion. So I was able, after 6 years of being able to actually recruit a VA employee, vascular lab tech, this was approved in June. It went through several layers of approval, including the central office. And once we obtain the special salary, which you can look at your GS level for 7, 8, and 9, and multiply the rates by 1.6, is what I was able to post for a vascular lab tech. And I am happy to say that within a month and a half of having competitive salaries, I recruited 2 of the best vascular techs that you could ever imagine. So this is a proven way that you can accomplish a better salary level for your vascular technologist in your hospital. It does require dedication and really close work with your local HR. So I wanted to make sure people knew about that. I'll talk very briefly about the rest of the vascular lab issues, scanners, PACS systems. The purchasing duplex scanners takes a lot of patience, just like anything else in the VA system. I don't have a lot of answers for that. Installing a PACS system is something that I think Lori has accomplished. I've used my time to talk about salaries, but this is another great topic and a huge challenge within the VA system to bring your lab into the 21st century and use a PACS system to collect and standardize the image display. And so I'll stop there with that piece about the vascular lab. The last slide set would have been by Jason Johanning. Jason had a last-minute commitment, and he sent his apologies for not being able to present this. But I believe I can push my way through this. So I have to admit, I've not seen these slides before, and I'm looking at great pictures. But the problem that the VA faced was the title on the first slide, unauthorized commitments. If I need to do an endovascular aneurysm repair, and I look at the images and I say, well, this is going to be a nice Medtronic 2-piece endograft for whatever reason, I think Medtronic is going to be the best, and I call my Medtronic vendor rep, and he brings the pieces in, which is what we have done for years and years and years. I have committed what's called in VA parlance an unauthorized commitment. I have authorized the federal government to buy $20,000 worth of implants without going through contracting, and that is basically illegal. So the VA this year, and we've all suffered through this now, starting in the summer, began a rollout of a consult system whereby we obtain authorization from contracting to purchase the endograft of our choice, the endograft we believe, for whatever clinical reasons, would be the right vendor, the right type of graft, but we have to submit a consult first and get formal approval from contracting. So the National Surgery Office worked really hard to try to make this as simple as possible, and this consult really only has to have 3 pieces of information: the date of the anticipated surgery, the name of the procedure as simply as endovascular AAA repair, and third, the anticipated vendor. And if you're planning a complex procedure that might require a combination of implants, you can put more than one vendor on the consult request. Any member of the team can complete this. It can be your vascular nurse. It does not require a surgeon in most facilities to complete this consult, and at White River, we use a very good PA who's vascular savvy and is fantastic with these forms. And the requirement for this consult applies to anything that the VA hasn't already paid for and doesn't already own. And so for us, it was a little bit of a challenge at first to figure out what the VA owned that was on our shelves, what was on one of these illegal consignments, but we finally got that sorted out, and so that works very well for us. Things are a little bit different with emergent procedures and emergent processes, and you can imagine that in many cases, if it's a true emergency, you basically have to use what's on your own shelf anyway. But if it's a very urgent or weekend case, then there have been some speed bumps and challenges as people tried to work through this. And I think that's it. That was the one slide that Jason sent to us. And I have to say that for most of the facilities I'm familiar with within the VA system, while it was a foreboding at first, these little images of keep calm and don't pull your hair out, and if everyone could relax now, that would be great. Things have actually managed to work pretty well, and this I think the VA pulled this one off again with the strength of the National Surgery Office forcing the VA Central Office to make this as simple as possible. We can do it pretty successfully and without too much frustration. So that concludes the formal slides. We have a couple of other questions here. The first one is has been submitted, and it says, I joined the VA 3 years ago, but did not get my market pay evaluation after 2 years. So a person who's been an employee for 3 years, and as I would understand it, and James will clarify, I believe everyone deserves a market pay reconsideration at 2 years. And the question is, am I eligible for this now, or do I have to wait for next year? Dr. Goff?
Yeah, so the short answer to the question is by regulation, and if you have an HR person who's a stickler for this, it should be done every 2 years. And traditionally, it's done right around the time of your anniversary date. The folks that are savvy about how to manage this would look to see what the proposed salary would be, and also factor in the amount of time it would take for any additional approvals, meaning does it need to go beyond the facility director, does it need to go to the VISN, or does it need to go to VACO based on the dollar amount? The specific answer to your question is you're overdue. You're eligible for a compensation panel now. You're delinquent, so you should talk to your section or service chief. You may need to chat with your HR folks about doing that now. What's required to do that, though, is the service then produces a memo with a new proposed salary that goes to the compensation panel. The compensation panel is made up of people that are in the same table and tier. So now that Table 4 has expanded, it's got to be, if you are a rank and file surgeon, it's someone who's another rank and file staff provider. if you're a section chief or a service chief, you have the appropriate people on the panel, and that's signed off and then sent through the process from HR and to the director and then outside the facility as need be. So the short answer is yes, it should be done every 2 years. Yes, it's by regulation, and yes, you're overdue, and you can ask for one now. You do not have to wait. And then Mike sent me a question here that talked about what would happen if you couldn't pay somebody at the top of the table. In other words, what if your facility said they weren't going to do that? I will tell you what really drives that more than anything else, now that I've spent far too much time in the front office in the last 18 months, is that that's really driven by what the facility budget is and what the director's priorities are and how well that's articulated. So for high dollar earners that are now on table 4, for example, you want to retain or recruit a new vascular surgeon and you want to pay them at the top of the pay scale. I will tell you, most directors will then look at you and say, are you serious? You want to bring on somebody sight unseen at the top of the scale. Most people will not do that. They'll back off of that a little bit, and they'll take it back for a variety of reasons. Some of the things I've seen used to adjust that salary backward a little bit are they board eligible versus being board certified? Are they in a supervisory role versus a non-supervisory role? How big is the service or department that they're going to be in charge of? All those things kind of go into that pay consideration. So the fact that we now are fortunate to have an elevated amount is great. I think we have to be careful with how we use it.
Thank you. And could you just tell me is there a directive regarding whether the existence of a new table can trigger a reconsideration, or do you just have to there's a new table, but you have to wait your time?
So I just had a discussion with our VISN HR person about this yesterday. And I asked her that specific question, meaning that now that we have a new pay table, am I going to have a run on the front office of people saying they want to be reconsidered now that we have a new table? The short answer goes this way. She could not cite a directive that says you can't do that. But the caveat goes like this. The people that need to be considered first are people who are due compensation panels. Those are easy. They're not going to be a problem. You'll be able to get through those. The second group to consider looking at are people that you either have a hard time recruiting or a hard time retaining. So, and Bob, to your question, if you have a group of providers that you're having a difficult time retaining, a good example where I am locally is we've had a mass exodus of ED providers, and now they're in a different table. One of the considerations is as you recruit at a higher salary, also bring the other people up to a salary that's competitive so they don't leave. So that's the second consideration. And they'll allow you to do that. You have to justify it, and you have to have the support of the facility leadership. The last thing that's a consideration for services and providers and sections with the new pay table is, do you have with your current providers a massive pay disparity from the old table to the new table vis-a-vis what's going on in the community? We had this a couple of years ago in our facility with psychiatrists. They were being way underpaid compared to the community. We were having people leave. And so what we decided to do as a retention tool is we repaneled all of them at the same time so that they became more competitive, and we were able to do that out of cycle. So there are some mechanisms to do it out of cycle, but it's got to be well justified.
Excellent. Thank you. There's one more question on the board, and if any of you are thinking about typing in some questions, please go ahead and do it now. The one question that came up regarded the Vascular Lab salary survey, and the question is, what Hay Group title did you use for your vascular technologist salary survey? Because the question goes on, did not seem to have one specifically for vascular lab tech, and that is unfortunately correct, I believe. The group that we used for our salary survey was cardiovascular technician 4097, and it's a melting pot of different things. And so cardiovascular technician, as you can well imagine, includes such relatively simple tasks as people who record electrocardiograms or Holter monitors, but also those who do cardiac stress tests and, quote, various arterial and cerebral vascular studies. and so there's a huge range of salaries, but the annual median total cash compensation with this group in Hay was only $52,000, and so that was pretty discouraging. But it was our local salary comparisons, and in particular the New England area, that had a very significant step up in the Hay data based on geographical differential. So it was that regional step up plus the competition, and our people in HR went to great lengths to obtain actual salary data from local hospitals, which was probably the driving force in our successful effort at the salary survey. So any other questions? Yeah, so hearing none, I'd like to thank the people that took the time out in this holiday week to listen. I hope that this presentation has been useful to you. I do want to say that to some extent this is a tiny bit of a preview of the VA seminar, the VA breakout section that will be held this coming June 2017 at the Vascular annual meeting. We'll be putting together what we think is a real star panel of VA surgeons to discuss a variety of key topics within the VA. So I don't see any other questions. Any of the speakers have any last-minute comments or questions?
Bob, this is Jim. The only thing I would say to the folks that are still on is feel free to download the slide sets for any of us if you have a question, because I think there's a lot of good information here. And the other thing is all of us will be more than welcome to answer your questions. We're all in the VA email, or many of our email addresses are on the slides, and I think sometimes people have very specific questions they like to discuss. I'm happy to take an email or discuss anything by giving somebody a call. Particularly for pay issues that I think people struggle with, I could give them some insight how they could be successful at their own facility.
Super. Thank you very much. Well, on behalf of the speakers in tonight's session, I want to thank all of the participants and listeners, and have a happy holiday season. Good night.
Good night.
Great. Thank you, Dr. Zolak, and
You're
thank you
very
all
welcome.
our speakers. On behalf of SVS, I would like to thank our presenters for a great program, and you, the audience, for your participation in today's event. You will now be directed to complete an online evaluation form. Please share this link with all participants at your site. Please take a few minutes to complete this short survey. This concludes today's program. Thank you all, and have a great day.
Thanks, Tyler.
Thank you.